Right, thank you very much. So this short case brings together, I think, a number of points made during this conference, and I think also extends what we heard yesterday about the molecular detection of antifungal resistance. Also, basically, in addition, my talk about Aspergillosis serology. So this is a patient that was brought to our MDT. Every week we have an infectious diseases National Aspergillosis Center MDT every Thursday morning. So this was brought by some of the hematology team in another of the Manchester hospitals looking after this patient. So no conflicts of interest. So here we have a 45-year-old male and is known to suffer from Job syndrome. So this is hyper-IgE syndrome. So what do we know about this? Not a lot, I suspect. It's not something which we probably come across very often in our clinical practice, but this is all to do with a STAT3 mutation. And so it's an autosomal dominant primary immunodeficiency. And this is something we haven't really heard about much in this conference. These patients, it's extremely rare, they get recurrent eczema, skin abscesses, usually caused by bacteria, and they get lung infections. Why? Because there are a lot of lung abnormalities in these patients, so we have a large cavity formation. So you can see where I'm going with this case in terms of a fungal infection. They get sinusitis, eosinophilia, which again is a reflection of a hyperimmunoglobulin type of situation, and they have very high levels of serum IgE. So in some ways, this case is aimed at immunologists, any in the audience. Let's see how we get on. So, oops. Okay, so the past medical history, this patient had a right-sided thoracotomy for a staph lung abscess 37 years ago. And diagnosed with CPA, chronic pulmonary aspergillosis. So let's perhaps just briefly go over what are the hallmarks of this disease, what are the essential diagnostic criteria. Obviously, imaging is one, positive sputum culture is another one, high levels of Aspergillus IgG, and so on and so on. These are the usual diagnostic criteria that we try to meet to end up with a diagnosis of CPA. So our centre looks after a lot of patients with CPA. There are about 3,000 of them in the UK, 65 million population country. And this patient, we were isolating pan-azole resistant Aspergillus fumigatus. So this raises a second point, which has been alluded to in this meeting, fungal culture, and a number of speakers have said how insensitive fungal culture might be. In this case, that wasn't a problem. But after, a few years ago, because we were completely dissatisfied with the standard in the UK for processing and culturing respiratory specimens, i.e. a very small volume of a bowel or a digested sputum sample, we've ended up with something which we published a lot about now called high volume culture. So we might be plating out 5 mils of a bowel or 5 mils of a sputum sample. This obviously takes up quite a few culture plates, but wow, the increase in sensitivity is almost the same in the setting of CPA as Aspergillus PCR. So other important parts of the medical history, chronic rhinosinusitis, ongoing problem, and underwent a FES 11 years ago, ulcerative colitis, chronic kidney disease, and prostatitis. So the mycology results here. So this, again, introduces something which has now become part of our routine practice. So first of all, we have Aspergillus PCR, and this was talked about a bit yesterday, any sort of cutoffs. So a CT value of 28 in our particular PC system, it's the Elitech platform and kits that we use for Aspergillus PCR. It's Aspergillus species, so it incorporates beyond fumigators. Then we have introduced a primer just for fumigators as well. Anyway, this is regarded as a positive result. So then we do pyrosequencing to find out what mutations are involved, possibly in this organism. And So pyrosequencing goes far beyond some of the commercial kits that we were introduced to yesterday, with quite a short list of mutations, which we know confer resistance to azole antifungal drugs. So pyrosequencing will detect more than 50 mutations, which we know in combination especially do confer resistance to azole antifungals in Aspergillus fumigators. So based on the pyrosequencing result, we have this combination of polymorphisms, and we can assign sensitivity or resistance as shown here. So the organism from this patient resistant to ITRA, sort of intermediate to voriconazole, and possibly susceptible, intermediate or resistant to posaconazole, so not very useful in terms of posaconazole. And then we look at this additional polymorphism here. We have resistance to ITRA and POSA, and sensitivity to voriconazole, and so on. So this is how we can use pyrosequencing to assign whether or not this organism is going to respond to a particular antifungal drug. So some of these patients with CPA are on azoles for life. So we have to be very careful, and we have to change the antifungal treatment based on this acquisition of resistance. So we can also get, obviously, some information from the basic MIC. So this is using the UCAST microbroth dilution method, and we can see here, looking at these MIC values and the designation of resistance or susceptibility for the various drugs that we use in a standard panel. And of course, this can be extended. But just notice here the last drug that was part of this panel, micafungin. It's not a drug we've heard anything about specifically in this meeting, but very, very sensitive. This organism, very sensitive. So this is a summary of the antifungal history in this patient. So the patient was on ITRA until 5 years ago, stopped because of the treatment failure with pan-azole resistance. And we see this a lot in patients who are on long-term azole drugs. And of course, we are all familiar with the various mechanisms which might drive resistance in Aspergillus, whether it's environmentally acquired because of the use of azoles, very similar to the azoles we use medically, azoles used in agriculture, but also the other driver is this chronic exposure to a drug like itraconazole. This has been well described over many years from Manchester, and also in great detail from the group in Nijmegen in the Netherlands. Nebulized amphoB was trialed, but because of intolerance was discontinued. And then there were 2 3-week pulses of Mica, poor control of the CPA. So Mica is a drug that we do switch to in case of azole resistance. And we understand all the problems with micafungin intolerance, which I'm sure the ID doctors in this audience will be very familiar with. So then the patient was switched, and this is pretty typical in terms of the progression of antifungal usage in these sorts of patients, switched to IV liposomal amphotericin B, but again stopped due to acute kidney injury, and a 3-course of micafungin pre and post lobectomy. So posaconazole was also used in this patient. Again, we saw from the pyrosequencing results that yes, this isolate was sensitive to posaconazole. But again, not unexpectedly, the isolates that we were getting became pan-azole resistant. So back to micafungin. So we have various CT images here, 2.4 years ago. As we can see here, this change here, and again, just summarizing the past medical history. So this was now assigned, this patient was assigned to have semi-invasive, slowly progressive pulmonary aspergillosis in the setting of hyper-IgE with the recurrent isolation of pan-azole Aspergillus fumigators. So here we're having no problems in isolating the organism from sputum culture. But patients with, in our setting, in our center, who have clinically CPA, quite often we don't actually get a culture. So right upper lobe and middle lobe lobectomy 1.7 years ago, followed by a right lower lobe lobectomy 1.5 years ago. And we can see here these changes and the CT appearance. And more shown here. So after completion of right-sided pneumonectomy. So carrying on the story, a year ago, reduced intensity conditioning sibling donor stem cell transplant was carried out in April 2022 with the standard sort of regimen to really ablate any immune response in this type of stem cell recipient. Pretty standard regimen here. And cyclosporin was given for GVHD prophylaxis, again a common sequelae in these patients, and some steroids and so on and so on. We can see those here on the list of medications this patient was given. And so this is all carried out in the setting of peri-BMT, both micafungin and liposomal amphotericin B. So after this, back to the micafungin pulses, but severe side effects, well-recognized side effects with micafungin. So the mycology then, until 2 years ago, so this is like sort of 2020, the sputum GM, so we do a lot of work on sputum galactomannan testing. We've tried to set a breakpoint, a threshold that's virtually impossible, of course, considering the nature of sputum as a sample to detect this analyte. But crudely speaking, we think an index of 6 is indicative of a high burden of a fungus like Aspergillus. So here in this patient, we have a range of 5.4 to 8.4 galactomannan indexes. And this is quite typical in these CPA patients. Can we use this long term to see whether there's not any clearance of the Aspergillus? That's a very good question. Specifically looking at Aspergillus IgE, this is the range here over this period of time, 38 to 49, and the sort of the background so-called normal range is of course much lower from 0 to 0.35. And looking at the Aspergillus IgG and thinking and remembering what I said yesterday, this is now going beyond the precipitin test. This is now using the immunocap system where we can come up with a numerical value. So a threshold, positive negative threshold, has been set over the years of 40 milligrams per liter. Above that, we think this is a significant level of IgG. And here in this patient, we have a range between 100 and 295. So this is a high level. These are high levels of IgG against Aspergillus. But now, much more recently than 2 years after this, the IgE has come right down, the IgG has come right down, almost to sort of background levels, and the sputum GM, just a background level of 0, an index of 0.1. So the patient is non-productive, no recent cultures, or Aspergillus PCR results of any significance. So this is the current status now of this patient, off all antifungal therapy for 6 months. The CPA seems to be in remission following this right-sided pneumonectomy and the subsequent stem cell transplant to correct this primary immunodeficiency of hyper-IgE syndrome. Exercise tolerance is still limited and referred for pulmonary rehabilitation. Yes, skin GVHD, but that has been well managed. So the CT angiogram now, presently, well, actually in 2022, satisfactory opacification of the normal caliber pulmonary trunk. I'm not a radiologist, so my understanding of this type of information is not particularly helpful, I don't think. Anyway, so there were no pulmonary emboli, normal cardiac size, and no significant intrathoracic lymphadenopathy. Median sternotomy, the bone sternotomy has yet to heal with slight AP displacement of the inferior sternal fragment. So there is some healing issues here, and the rest of the report can be seen here. So resolution of a moderate size pericardial effusion, the left lung is clear, the tiny right paratracheal air cyst. So the questions that were brought to the MDT by the hematologists were, how do we interpret the antibody levels post-BMT? How long do we carry on treatment for this patient, sort of maintenance treatment, secondary prophylaxis, with what and how do we monitor? So they're the questions raised by the MDT. So there was a lot of discussion about all of these points. We can come back to this slide after me just presenting you with a case from the literature. There are quite a few of these. There was a series from France of patients with hyper-IgE syndrome, a vast proportion of which did have CPA. So it's not a rare finding in these patients. So here we have just a single case that was published in 2021. This is a patient with chronic pulmonary disease, a young male, bacterial pneumonia, skin infection, elevated eosinophil counts and high serum IgE, hence the designation of a hyper-IgE syndrome. On CT, pneumococele and bronchiectasis. So this was, again, this genetic mutation in the STAT3 gene. And 14 months later, blood-tinged sputum in hemoptysis, a dangerous sign, of course, and on the chest CT, there was wall thickening, a fungus ball, a mycetoma, and consolidation. Sputum culture was positive for Aspergillosis fumigatus. Here, precipitin testing was done, positive. Lactomannan was positive. So similar findings to our own patient, and CPA, based on all of this, was diagnosed. So this patient was treated with voriconazole and a right-side bronchial embolization. And that's a pretty typical procedure that's done by our interventional radiologists with patients with CPA. It's quite effective, especially to prevent all this repeated hemoptysis. Symptoms improved and the patient was discharged. So back to these questions then. I can pose these questions, and it'd be very interesting to hear from the panel or anybody in the audience who might have a view about these questions which were posed by the hematologist at our recent MDT. Thank you.